Awesome. All right. So this is a case from Dr. Seacoman. Thank you so much. We've got a 44-year-old female noticed a vision problem in her left eye for 3 weeks. Since it started, it hasn't been getting any better. She's been on Flonase for less than a year, also on systemic prednisone, 5 milligrams per day. 2 months ago, had a lupus flare with 10 milligrams, and now she's down to 5. She's taken systemic steroids in the past, 35 milligrams for autoimmune hepatitis, and at these times, she has had no problem with her vision. She was initially seen for plaquenil screen and was fine about a month before the vision got worse. Her meds include plaquenil, Celsep, Flonase, and ursodiol. And her visual acuity was 20/20 in the right eye and 20/25 in the left eye. And the left eye is the problem eye.
So we got fundus photo of the right eye. The media appears clear. The disc looks pink, sharp, flat. Vessels look normal caliber. Macro looks flat. Looks like a normal fundus photo.
Nice.
We have a fundus photo again of the right eye. It seems like it's just a little bit more, I guess, nasally.
Yeah.
But looks the same. I don't see anything else.
Yeah.
Spots are artifacts.
Because they
This is
don't
my
move.
little camera.
They don't move from. Oops, I'm sorry. Oh, that's fine. Sorry. Yeah, they don't move from picture to picture. Like you see how they stay in
Yeah.
the same spot. So
That was nice. There's a Canon camera. It was before we had the fancy ones in Claris, but the Canon used to give you 60 degrees. It was the artifacts right there. It's a funny option.
to hear.
Is this the one I just spoke about?
Oh,
It's the other eye.
Oh, so one is one of the left eye. So media looks clear. The disc looks like it's polaris. And it seems like it's a little bit more edematous.
Yeah.
Or just artifact?
Here, I think this
Okay.
is a better picture.
Okay, so never mind. The nerve looks pink, sharp, and flat. The vessels look like they are normal in caliber. The macula in the kind of entire posterior pole appears a little bit more white, and then centrally in the fovea, there's like a
Pale.
That's right. You're first here. You second. You started.
how should I
You
set
see
it?
any,
White
any,
instead?
any 3D cues from a 2D image there, or?
Not right superior to the
Yeah, I mean, it does look white and pale. Superior to the fovea. And then there are a couple of like little white dots I think I'm seeing in that area as well.
Oh, yeah.
Yep.
Those are probably real.
Yeah, there's a little white dot.
Like you saw the red on the passion case.
Mhm.
Oh, do we have that little zoom thing?
Here.
And is that little like white kind of circular area in the infratemporal aspect
Yeah,
Artifact?
double tap it.
also?
I think it's outside.
Yeah, right there.
Mhm.
Little white-
I don't think people on the internet can see that. but
Yeah,
it's like, ooh.
okay, I think these spots are all artifact.
Including that little white one.
Yeah,
Okay.
there too.
Okay.
Nice.
Okay, so we have, this is a IR of the right eye. I'm drawn to, I guess, the normal
Mhm.
architecture. The IR of the left eye, there is, a
You can
large
give her the mouse.
Oh, yeah.
You can advance on it.
hyporeflectance in this region here, kind of involving the fovea and then superiorly as well.
And one of the things IR shows nicely is hyporeflectance sometimes means subretinal fluid.
Mm.
The IR is good for a couple of things. One is subretinal fluid. The other one's acute macular neuroretinal. For some reason. It's the only picture they'll show.
So, this is an autofluorescence of the right eye, and it looks normal from all the AFs I've seen. This is and the same thing, autofluorescence of the left eye, and it looks like it's the hypofluorescence, and then a central or like superior kind of portion of that is hyperfluorescent.
So when you see hyperautofluorescence, there's two things that can cause that. Do you remember we talked about that last month?
Yeah, it's of hyperfluorescence.
Hyper on an autofluorescence.
Oh, is this
Two-
like a,
right.
a defect or?
There's you're seeing more of the underlying by autofluorescence, or there's more being, you're getting excessive emission,
Mhm.
or you're seeing more of the underlying because there's like a window defect. In this case, it's probably, can you guess which of those two?
The window defect?
No, it's probably
No.
excessive emission, because what happens when you get a serous detach, the autofluorescence. And get too much on you. Do you remember where the autofluorescence comes from? Which chemical emits it?
It's that one, is it like AF2?
Yeah, it's a lipofuscin.
Okay.
Those two come together. So lipofuscin does it. Lipofuscin is made up of it comes from the outer segments of the photoreceptors being absorbed.
Mhm.
So the other thing that can autofluoresce is the outer segments of the photoreceptors.
Okay.
So when outer segments shed into a cavity,
Mhm.
you can get a little pocket of autofluorescence. So these images are kind of cool. So that's a nice example of hyperautofluorescence from an increased source.
Okay, so we have an OCT of the right eye. There's good foveal structure and all the layers look intact. This is an OCT of the left eye, and there does look like there's a large intraretinal kind of cavity, a fluid pocket,
So is that intraretinal?
or subretinal,
Yeah.
subretinal, because it's in
Yeah,
our
perfect. And then, if you use your mouse, can you find some other little opacities there that are,
In the subretinal space.
Oh, here?
Yeah.
There is a little opacity here.
okay,
Just a kind of irregular opacity.
Yeah.
Okay. So similar photo, OCT photo, same little opacity there, and then same subretinal fluid.
Now, these are EBI images. So
Oh,
these are
okay.
to look at the core, they're OCTs, but look at the first, go to the first one there, that one. That's not an EBI, so you're seeing the vitreous,
Okay.
but you're not seeing the choroid. But if you do the EBI, you get the choroid, but you
Okay.
lose the vitreous. And so you're looking at the choroid, it's a little bit thicker than it should be.
Okay, so I've got another EBI. Seems like it's the same.
what do you think those are
Mm.
kind of closer to? the
These?
Yeah,
These are just like PEDs.
Yeah. awesome. And those little dots above it.
The kind of pigment floating up.
I would just call them like hyper-reflective spots here.
Those are probably shed photo. outer
Shed
receptors.
photoreceptors.
That's what you were seeing on the autofluorescence image. Those little spots were
Oh, okay,
lighting out
okay.
because of the outer segments.
So we have an FA of the right eye.
Mhm.
I'm
I'm gonna go through these a little
Yeah.
bit so that,
Oh, go back one. There is one little finding.
yeah, there is. I'm trying to go through it so it's
That's
a
okay.
Is
little,
it this little area here?
Yeah.
yeah, exactly. And see how it,
So a little bit of leakage up here.
Well,
yeah, maybe more staining. Yeah.
if the edges don't. change,
Oh, okay,
right?
yeah.
So it's more.
And it doesn't really increase
I
that
don't
much from
remember.
the early to the late.
Mhm.
I can't see quite what time this is at, but I believe this is a pretty late one, like maybe at
Yeah, it's
15
probably
minutes or
pretty late.
something.
Yeah, fine.
And if it was leaking, you would expect the borders
expand.
to be a lot more feathery, yeah. So, I'm gonna go through these and then we'll go
Okay.
back, okay? This is the left eye. I believe that's the last one, so we'll go back.
So that one's expanding, so I think that's leakage.
And you can name the arterial phases
Yes.
from the beginning,
Oh, okay,
or the phases of filling.
So go back one more.
Yep.
There.
Okay.
So what's that one?
so the arteriolar phase.
Good.
Yeah.
Arterial. And now you see a little bit in the
Little bit.
veins.
Mhm.
What's this one called?
The vaginal.
Right.
Laminar, okay.
Mhm.
Come on.
And then this is the vein phase,
Yeah, veins.
venous phase, okay.
Or some people call it peak. That one is the brightest. Venus with peak.
Okay.
And then you get later, the veins get lighter since recirculation.
Okay, so, sorry, oh, just the leakage.
Yeah.
So the right eye, the
Do you know what
FA,
image this is? This is a different image you bring.
oh, ICG.
Because you're seeing the choroidal vessel. So this is an ICG.
Oh, okay, gotcha. So ICG of the right eye appears normal.
Maybe something
You
up
got this little-
there.
Just the kind of areas of hyperfluorescence.
Good. Okay.
Right.
And then for the ICG in this disease, yeah, it's about 5 minutes in, you'll see sometimes areas of differential leakage. So that area above the nerve, you see how it looks like a little bit brighter?
Mhm.
That means it probably, because your chorioretinopathy is supposed to leak. So, but in this disease, it leaks a little more than it's supposed to in certain patches.
Okay, so ICG of the left eye. It looks like 3 areas of leakage, 2 in the posterior pole and 1.
And that's helpful if you're gonna do laser for this disease, photodynamic laser, you generally want to get. If you go back one on the eyes, that little area above the fovea, that whole, not just the dot, that whole smudgy area, you probably will PDT. You know, you're not hitting the fovea, so there's no harm. You could even do a bigger spot and take in the whole thing. And that way, you're kind of lasering the leaky chorioretinopathy.
Outline the area you would treat, please.
Oh, you have to do it with the mouse. Do the mouse.
Oh.
So follow that pointer. See my pointer? Yeah, that area, and then maybe even taking that area up and to the right a little bit. Maybe even taking that. Does that make sense? So I would at least treat that area. It's about 2 disc areas or 3 disc areas above the fovea. And then maybe even taking that. I probably wouldn't actually. I would just hit that area. But I wouldn't just treat the hot spot.
Would you treat that at the initial visit?
No, hardly. But if you have to.
Okay, so I don't remember how old our lady was, but she has had a couple, I think 3 weeks of left eye blurred vision. She has a past medical history of lupus, on Plaquenil, on steroids, on intranasal steroids as well. Her imaging was notable for an area of leakage in the kind of superior part of the posterior pole, and also nasally to the nerve. Differential.
And then she's 44.
And what was that?
She's 40.
She's 44. If she's on Plaquenil, I would put like Plaquenil toxicity on the board, but I didn't really see that full side.
She's on steroids.
Steroids too, but isn't she also on Plaquenil?
Yes, she is.
She is, okay. Steroids impacting the retina.
You can get help from the upper class.
Help.
I'm here for those questions. You guys on the-
Steroids is a good name.
Oh, yeah,
Yeah.
we got your retina for that.
Yeah.
Yeah, nice, very good. So I summarized the findings first. The fundus exam showed serous macular detachment, small yellow subretinal deposits in the area of the detachment. IR with a circular hyperreflectivity corresponding to the area of subretinal detachment. The subretinal fluid on OCT also had some PEDs and maybe some subretinal fibrinous exudate, which I saw like someplace to say denoting the site of leak. That was
It
that
could be
little-
fibrous, and it is a thing with females. There's something about central serous in females where you probably get a little more subretinal fibrin.
And I read that it was also more common in pregnancy to
Oh,
get that fibrinous exudate. And then expansile dot on FA, kind of a similar appearance on ICGA. And then the other thing on ICGA, well, I guess I'll go into this later, but we didn't see any guttering or anything like
No.
that you will often see on there. Choroidal vascular hyperpermeability in, I meant to change that to asymptomatic eye, but essentially that was that little spot that was staining in the other eye. So the differential is quite broad. I kind of made it longer, but central serous chorioretinopathy obviously being the top one. Polypoidal can also look like this, which is where the ICGA is very helpful, age-related macular degeneration, anything that causes NV, myopic degeneration, anjoid streaks, multifocal choroiditis. Optic disc pit can also cause that serous fluid as well, subretinally. And then choroidal tumors like hemangioma, melanoma, metastasis. This is getting less and less likely, but I wanted to include it all. Inflammatory conditions like VKH can also cause this, serous RDs, RPE dystrophy like BESS, and then preeclampsia in pregnancy. An ophthalmologist can actually be the first one to catch something like that for a pregnant woman, so that's important to know. So the diagnosis was central serous chorioretinopathy. It's associated with stress and stress hormones, corticosteroids, and epinephrine, typically seen in individuals with type A personality. It's also been seen with medications that are PDE5 inhibitors, sildenafil. There's something about like dilating the vasculature of the choroid, and then MEK inhibitors, which are used to treat metastatic cancer. And then I've also seen patients on testosterone that have come in with CSR. Exposure to exogenous corticosteroids, and then there's also endogenous, which I'll go into, but even topical exogenous steroids, so those with asthma, autoimmune disorders, dermatologic, allergic rhinitis, degenerative disc disease, organ transplant patients as well. Exposure to endogenous corticosteroids, if someone has Cushing syndrome or if they have OSA or hypertension, they're more susceptible as well. But interestingly, it's not associated with intravitreal steroids. So the
You know,
BCS
I have a patient with birdshot who went to Boston, and Foster put an implant in her, a steroid implant. She got central serous.
Oh, interesting.
So I've seen that. That's more published, but I don't know that it's completely true. Maybe her levels went up. But go ahead, sorry.
What about Latino?
Yes, it's true. I've not seen it. I've not induced central serous in anybody to my knowledge. So it does seem to be an exception. Maybe there's something systemic going.
Yeah.
I mean, at least there's some.
There's some
There's a
systemic.
nasal mucosa.
Yeah, but I've seen a lot of central serous. I've seen tons of people on topical steroids and intravitreal everything. I mean, the Ozurdex, there's all the registration studies for the Ozurdex and the Illumina. I don't think so it does seem to be a thing.
It often presents with a variety of symptoms. They can have blurred vision, micropsia. The patient I saw had very significant micropsia. He was like, everything looks smaller in this eye, which is very interesting. Metamorphopsia, pericentral scotomas, and decreased color vision. The age range is typically 35 to 55, and it's more common in males, about a 3-to-1 ratio. Although I've seen it like in my research about as high as 6-to-1. Usually, but that's what the BCSC says is 3-to-1. Usually unilateral, but can be bilateral in up to 40% of the cases. Majority have PEDs in the other eyes also, and then bilateral changes in choroid are usually noted on the OCT. And that's with the enhanced depth imaging OCT. So the basics of the pathophysiology that's proposed is choroidal hyperpermeability with altered RPE function results in that subretinal fluid. Choroidal inflammation causes stasis and ischemia. The vessels become hyperpermeable and choroid thickens. The increased tissue pressure then disturbs the RPE and causes a PED. And then because the RPE barrier functions are compromised, the choroidal fluid basically crosses over and causes a neurosensory detachment. In the imaging on enhanced depth OCT, you can see a thickened choroid with a dilation of the large vessels, and that's from the Haller's layer. So I put a little picture up there as a good refresher. But that's the top part that's closer to the Bruch's membrane is the Sattler's layer, and then below it is the Haller's layer. And so those are the large vessels that are dilated. And then there's compression of the overlying choriocapillaris, which is the red dotted line on the top right image. There's a serous attachment present on fundus exam. There's attachment of the neurosensory retina on the OCT associated with PEDs. And then the OCT can also have those punctate reflectors that we were talking about, those white dots on the retina. And that I read were macrophages with fluorophores from phagocytized outer segments. So it was essentially like that molecule that hypofluoresces. And then leakage through the RPE on FA, which results in a smokestack or an expansile dot. In our case, it was an expansile dot, but with a smokestack, you'll typically see like a tree or a mushroom shape. And the expansile dot is apparently also called ink blot. ICGA may show hypoautofluorescence, guttering of subretinal fluid, and that's typically more present in chronic conditions. The natural history of CSR is 90% resorbs spontaneously in about 6 months. Cell VA usually returns to baseline. Residual mild deficits are common. They can have metamorphopsia. I don't know why it says metamorphosis. Nyctalopia, dyschromatopsia, and then 50% have recurrence. And then they can also have CNV in about 20% of patients age greater than 50. For management, obviously, if they're taking exogenous steroids, they should be tapered and discontinued. Address environmental factors, explore how they're sleeping, how they're working, if there's hypertension and medications that they're taking that are contributing to the disease process, those should be addressed. In type A personality patients, they actually get more anxiety and fear from the visual threat and of performance loss, so can consider psychological support for that as well. Acute CSR typically resolves within 3 to 6 months, and chronic is if the fluid persists longer than 6 months. Which is typically seen in older patients or those that have to be on long-term steroids for whatever reason. Observation is reasonable. 80 to 90% of the cases resolve in 3 months, but you treat earlier if there's recurrence, if any of these things are present. Recurrence in the eye with a previous deficit, decreased vision in the fellow eye from a prior episode, cystic retinal changes, widespread RPE changes, or occupational needs. Common treatment is photodynamic therapy, PDT, which essentially there's a light sensitive chemical called verteporfin that is injected through IV. We wait for it to concentrate the lesion of interest and then use light at wavelength needed to activate the chemical. The chemical reacts with the oxygen to create free radicals, and that degrades the lesion by damaging the vasculature. And then there's a questionable anecdotal benefit of mineralocorticoid receptor antagonists like eplerenone and spironolactone, but randomized controlled trials that I was looking up didn't show any benefit. Have you ever used it successfully, Dr. Pillar?
I don't think it works.
Okay. And then obviously if there's CNV associated with CSR, then anti-VEGF.
Are there any trials for people doing like low dose benzodiazepines?
I think in the old days, there might have been a value thought.
Yeah,
I want to say a long, long time ago, there might, I tend to, when people told me to relax, it just stresses me out.
exactly.
To do.
You're going blind, but relax.
Yeah, so I always
Meditation.
tell people, it's stress, but I tell them I don't bother, just, what are you gonna do?
Is the type A association just that those people have like a higher level of like endogenous corticosteroids
Probably.
going?
Yeah, I mean, there was a good study done on Cushing, so a long time ago, someone looked at Cushing, and they found, I think, 10 or 20% central serous in Cushing clinic, so it's kind of cool. So no, actually, next month, we don't have a conference. Oh, but we do in 2 months, just because this is a lot to set up, and I'm not gonna be here in need for section bound. So, but the rest of the year, it's the only one we miss, so we still come out ahead doing the second 5.
Dr. Pavin, you had something?
I don't buy the type A personality. I should have been blind a long time ago.
In the early days of cell phone, you could open the room and diagnose it, because it'd be like a 30-year-old guy on his cell. And it's like, okay, I don't even have to ask questions. Nice job on the presentation. You guys are doing a great job.
Pete, thank you. Wonderful conference, everybody.
Thank you. It's working pretty well. The second screen really worked nice.
Dr. Pavin, all your old patients are telling me to tell you hi.
Thank you.
Hello.
Hi back.